Essentially, a provider will talk to the patient about the various options for treatment.
That requires building trust. And so when a woman comes in and she's overwhelmed, how do you build that trust? She's not just a breast surgeon, she's a translator of hope, options, and healing. Meet Dr. Nina Tamirisa, breast surgical oncologist and associate professor, MD Anderson Cancer Center in Houston, Texas.
We remove the tumor and affected lymph nodes. We want to do this good balance of treatment. We don't want to undertreat just because age is just a number. Where I start is you have to take care of yourself, your priority, because once you get through this, you can get back to your activities. Shared decision making is sitting down, laying out the options. This is what this looks like. But then also hearing the patient and saying, okay, I hear this is what is important for you. Then you can come to a decision that aligns with everybody's priorities. I really hope that people walk away knowing that what they just went through and the treatment they just did is something to be proud of, and know that they have the strength within them to get through anything moving forward.
Today we have a wonderful guest, Dr. Nina Tamirisa. She is a breast surgical oncologist and an associate professor in the breast surgical oncology department at the University of Texas MD Anderson Cancer Center. Dr. Tamirisa, thank you so much for being here today with us on Sis, Sisters in Survivorship podcast.
Thank you. Thank you so much for having me.
So, for some of our guests, let's explain what a breast surgical oncologist, what you do.
So essentially, we remove the tumor and affected lymph nodes. Depending on the stage of disease, the biology of disease, patients would either be recommended for some sort of chemotherapy or medical treatment first, and then we go to surgery. Or in certain cases, we go to surgery first, but we will be involved somewhere in the middle or beginning of treatment for patients.
Okay, so you're very different from a general surgeon.
That's correct.
Okay, so the general surgeon, explain the difference.
So essentially, breast surgical oncologists are fellowship trained. So we do a year of breast only treatment.
Okay.
So we actually, through that year, we get exposure to multidisciplinary care. So we have the opportunity to work with breast medical oncologists, radiation oncologists.
Okay.
We work with some of the survivorship physicians so that we understand the breadth of care and the journey that patients go throughout their cancer care treatment. And so for that reason, we're specialized in sort of not only the surgical part of it, because there are general surgeons who can do breast surgery and removal of the lymph nodes. But I think a lot of what the fellowship offers is that additional sort of patient experience and understanding that multidisciplinary care, because it's so critical to them.
And so you're very different from just a general oncologist as well, because the oncologist handles the treatment options.
Correct. They're the ones who do the medications.
Right.
So we do the surgery part.
I got you.
Mm-hmm.
So I know in just learning a little bit about you, you really emphasize that listening to your patients is very core to your practice. Talk to me a little bit about, that philosophy and why.
Yeah. So when it comes to surgery for breast cancer, there's options. So breast conserving surgery, do we want to try to save the breast? Can we save the breast versus a mastectomy? So a lot of that really takes into account what the patient preference is. Mm-hmm. And not only that, for our younger or older patients, some of these surgeries or treatments may have quality of life implications. So I think it's really important to understand, if you're an older woman and it's really important that you be able to pick up your grandchildren and play pickleball on the weekends and things like that, that what we're offering to you for treatment is really tailored treatment. So we're taking into account that these are the important things in your life, but we also want to offer the best in the oncologic care. So balancing those two things is very, very important.
Right. So some of your patients, like you mentioned, may opt for, or need a double mastectomy or a lumpectomy. Can you kind of walk us through that process for each of those type of surgeries? Because we hear those terms so often, but I want to make sure people truly understand what that means.
Sure, absolutely. So essentially when someone comes in with a diagnosis of breast cancer, the options are a lumpectomy or breast conserving surgery. Typically, that's followed with radiation versus a mastectomy, which is removal of the whole breast.
Okay.
With breast conserving surgery, we just take out the tumor, but we leave the rest of the breast intact. So what we're able to offer depends on a few things. In terms of mastectomy, that would be for anybody who has a breast cancer. But for somebody who has breast conserving surgery or who wants that, what we need to talk about is the size of the tumor relative to the breast. So if we're going to take out the mass plus some margin of tissue around it to make sure we got everything out of the breast, we need to make sure that it's the size of that mass it will leave the patient with an acceptable cosmetic outcome.
Gotcha.
So those are kind of the two options. As far as a double mastectomy goes, that's often for patients who either have large amount of disease in both breasts or they have a genetic mutation. So we then start to get into those conversations. But just at the outset, the difference between the two is you keeping the breast, retaining the sensation and on all those things, and then versus removal of the breast, which has more implications in terms of reconstruction, what you're going to be getting down the line and things like that.
So if you have a patient who comes in and you're talking about the options and they're, for whatever reasons, their tumor is very large. And so they say, I still want to conserve this breast. I really don't want the full breast removed. And I definitely don't want a double mastectomy. But that breast can't handle because of the size, I'm assuming, is not going to be conducive to that surgery. What does that conversation look like? Because it's a very sensitive one, I'm sure.
Yes, absolutely. So there are still some options. Okay. So patients can get some sort of medical treatment first. So depending on the biology of the disease, for example, if it's like a HER2 positive breast cancer or one of these triple negative breast cancers for which we typically give chemotherapy, we would start with that treatment. So in starting with that treatment, the tumor actually can respond to such a degree where it shrinks. And then maybe at the completion of chemotherapy, we can offer them breast conserving surgery.
Oh, okay.
And then in cases where patients are not necessarily going to get medical treatment and they have a large tumor relative to the rest of the breast, what we offer, at least at MD Anderson, is surgery with a plastic surgeon. So what we can do is have different reconstructive techniques that still not implants and things like that. It's utilizing your own breast tissue or maybe some tissue from the back to kind of repair that defect. Okay. So options with reconstruction are there for women who really want to conserve the breast, but maybe it will be left with a large defect in the breast if we take that approach. And then starting with some medical treatments to try to shrink the tumor. Yes. Yeah.
So that's good to know that you coordinate with the plastic surgeon to complement your work and make sure that the outcome is what you're looking for.
Yes, absolutely. Very heavily. We work with our plastic surgeons very closely.
We hear a lot of terms, and one of which is shared decision making. What does that mean for the average patient?
So what that means is essentially a provider will talk to the patient about the various options for treatment. So really where it comes into play is where we have to make a medical decision that's right for the patient. But there are options and ways to also achieve what the patient wants. So shared decision making is sitting down, laying out the options. This is what this looks like. But then also hearing the patient and saying, okay, I hear this is what is important for you. These are your priorities. And this is, once you talk to the patient hears what the physician has to say, the physician hears what the patient has to say, then you can come to a decision that aligns with everybody's priorities. So our goal is to remove the cancer and really try to reduce the risk of it coming back, which is also, most oftentimes the patient's goal as well, but achieving that in a way that aligns with the patient's priorities. Yeah.
Nice. And so that requires building trust, I would imagine.
Yes, absolutely.
And so when a woman comes in and she's overwhelmed, she's scared, she's a host of emotions, how do you quiet that storm to make sure that she is hearing and listening and build that trust?
Yeah.
Because you're a new person to that person.
Absolutely. And we're both new people to each other. We have about 45 minutes to an hour to explain all of these decisions that have to be made. And it's extremely overwhelming for most women. And a lot of times I think women come in and they are the person in the family. They're the one everyone goes to. Yeah, the glue. They handle everything. They do everything. And so they're just thinking about, yes, what's happening to them, but then what is that impact going to be on the family as well? So I think where I start is you have to take care of yourself. This is the time now where your priority, because once you get through this, you can get back to your activities, your things, but breaking it down stepwise. So just making sure first that you understand what's going on with my body. What is this? What's happening?
Right.
And then a high level view of this is what we're going to be doing in terms of your trajectory of your care, because understanding where that falls in your timeline. I mean, there may be, you may have already planned a trip with the family or planned this or that or the other. So setting it out and saying, this is what we're really looking at. So this is how many months. And then once we kind of do that, I think that after that, I always try to ask, what's important to you? What matters to you? And then we're going to do our best to do whatever we can to treat this and make sure it doesn't come back.
That makes sense.
Yeah.
What are some of the most important questions that you like to see or encourage new patients to ask when they're coming in to see you? I know for Sisters Network, we have a document that's on our website under the resources. It's called What to Ask Your Doctor, from the surgeon as well as the oncologist, because there's different questions. And because we know during that time, people they're just not thinking. Yeah. And so we at least hope to give them a guide. But what, from your vantage point, are some important questions you would like people to think about asking?
Yeah. So I think it's important for them to ask, what does this, what are my options? And then once we kind of talk about what the trajectory of care looks like, so what the type of surgery and things like that, I think some important questions are, and it may be overwhelming in the first visit to ask about things like plastic surgery, reconstruction, and those things, but maybe who can you refer me to, or who do you think would be helpful to talk to address some of these concerns that I have at the outset? So when that happens, then it's very easy for me to say, well, I think it would be great to talk to a plastic surgeon, or I think it would be great to talk to an integrative medicine specialist who can talk to you about your diet and your exercise and things like that. So I think asking that question of after meeting with me and knowing me as a person in this time, who do you think would be beneficial for me to talk to and meet with?
For my whole care team.
Right, exactly.
Great. How do factors like age, fertility, lifestyle, and breast density play into treatment planning? It's
basically, we have the extremes of age, and then we have kind of the middle portion. So oftentimes, I'll start with talking about kind of the older patients. So for the older patients, it depends on the biology of disease, but we want to do this good balance of treatment. We don't want to undertreat just because age is just a number. Somebody can be extremely healthy, active, maybe older, but that shouldn't preclude them from getting standard of care treatment.
Sure.
So we think about their other medical issues and things they have going on, what their lifestyle look like, who they live with at home, their functional status, and then be able to integrate an appropriate treatment plan and maybe some supportive things that they would need throughout their treatment to get them through their treatment in the first place.
Right.
For the younger patients, we typically will offer consultation to the oncofertility physicians to talk about what the implications of the treatment they're going to be receiving are in terms of their fertility and preserving eggs and things like that.
And I know time, depending on the aggressiveness of their tumor, factors into whether that's even an option. Sometimes.
Right. Sometimes we have to kind of hit the ground running, but I think it's always a good idea to meet with the appropriate people, because once you start the treatment, you don't want to look back and say, oh, I should have talked to those people in the beginning. So there's always a little lead time to meet with the appropriate people.
That's really good.
Yeah.
Are you starting to see, I know we're getting a lot of calls from young Black women, and you know the statistics for African-American women and breast cancer, so I don't need to talk about those. But for the audience, Black women under 35 are 2 times more likely to be diagnosed with breast cancer, which is very alarming. And we're getting calls. We're seeing a lot of young Black women reaching out to our organization that are 25, 30, asking what should I do, or just in a panic. Are you seeing that trend with, women who are coming in, particularly women of color?
Yes, I think I am. And I think generally as a group, we've kind of talked about this anecdotally, that, the research does show that there are increased numbers of younger patients, and especially in women of color. But I think also just in my patient population, in the time that I've been in practice, I've definitely seen a rise in younger.
Yeah, it's just very, very concerning, especially so young.
Yes, absolutely.
I've seen some cases where a woman has been diagnosed with 2 different breast cancers, and one breast has a a type of cancer than the other one has.
Yeah.
I'm sure you've encountered that.
Yeah.
How does that factor into your treatment process?
Yeah, so it's not common, but I've definitely encountered that. And so usually in those situations, we will work very closely with the medical oncologist because we want to be sure that for the appropriate tumor biology that they have, they're receiving whatever treatment it is that they need first. So that is usually in the sphere of the medical oncologist and the treatments they offer. And then when we go to surgery, we'll typically just offer them the same options that they would otherwise have. But yeah, it's really the biology of the disease that's going to dictate the care that they get.
Yeah. You've said their outcome is my outcome. Tell us a little bit about that mindset.
Yeah. So it's part of what drew me to surgery, I think, is that I really care about my patients. And I think when you make an incision, you kind of own all the things that come with that. So it ties you to that patient forever. And for me to know that we've done the best that we can and that they have done well, it means that, hey, we got through this. So to me, it feels like, okay, I did well. Not that I did the surgery well or anything like that, but it just, to me, it just feels like we did something together. We achieved. And when an outcome, it doesn't go well, when something doesn't go well, then that also weighs on me. So as surgeons, I think that, and we've talked about this as a group many times, is that, once you take that person into your care and you're operating on them and it's a very close relationship that you have with that person, it feels like that. It's just like with your own family member, where if something happens, it feels like it's happening to you in a sense. So when people do well, it's a reason to celebrate. When people don't do well, it's a reason to kind of empathize. Yeah.
So when you talk about, because, we talk about the surgical outcomes coming out well, but like you mentioned, sometimes things don't go as planned. What are some of the challenges that can happen? Because we know that any surgery poses potential risk factors.
Yeah. So some of the major ones are lymphedema. So when we have to do a lymph node dissection, that's one of the known complications, or not complications, but maybe risks of the surgery. And so getting people through that, having them understand what that means in terms of their quality of life implications, pretty much moving forward for a while. And then I think with reconstruction, when patients have wound healing issues or infections that have significant implications in terms of needing to go back to the operating room and possible loss of an implant, or if there's a reconstruction that doesn't seem to be doing well and then having to go flat when you wanted to reconstruct the breast, but needing to go flat for a certain period of time in terms of no reconstruction to the breast.
Prior to that next step. Interesting. Yeah. So on average, a lumpectomy or a mastectomy, since those are very common, how long can those surgeries take on average? So lumpectomies are relatively faster surgeries just because we're just removing the tumor. So we're not removing the whole breast. If I'm doing just that and then maybe taking the lymph nodes, it's maybe a 1.5 hour, 2 hour surgery at the most. If it's a mastectomy, that depends on the patient's, the size of the breast and things like that. But usually with reconstruction, one breast, it'll be about 3 hours. If it's 2 breasts, that'll be about 5 hours. Are they requiring to stay in the hospital for those surgeries, or is it outpatient?
It depends on the surgeon, I think. So some will say, I feel comfortable even after a mastectomy sending you home, and they'll do that. And some of the physicians will say, I'd rather you just stay overnight. And typically it's a one night, and it's just a one night hospital stay. We don't really have more need to do that for it.
And we've seen the drains. Can you tell us about that? Because people see that. And how long do they normally have to keep those? Yeah.
So whenever we take tissue out from the body, in that defect, the body wants to create fluid to make up for that loss of tissue. So the reason we leave a drain is because, for example, in a mastectomy, we're removing a large volume of breast tissue. And the body is going to make fluid to make up for that. And the body typically reabsorbs fluid. So it doesn't just leave it there, it reabsorbs it, but we need to place drains to help the body catch up with that reabsorption. So we leave the drains after a mastectomy, it would be for about 2 weeks. And then we know that, the amount of fluid is enough to where when it's not so much that if
The
we
body can
remove,
handle
yeah,
it.
exactly. Once we remove the drain, the body can just reabsorb that fluid. So you're not left with any swelling or things like that.
Oh, because that's the outcome. It can swell.
Right. So if, for example, for a lumpectomy or breast conserving surgery, you won't necessarily see that because it's just that fluid is going to just fill the shape of the breast. So it's really not all that obvious. It's most obvious in women who go flat.
Okay.
And have no reconstruction. If we pull that drain out too soon, that fluid will accumulate to almost look like it's a breast.
Oh, wow.
Yeah.
Okay.
Yeah.
Okay. So again, you've been known for being thorough, present, and compassionate. What do you believe makes a good provider/patient relationship?
I think it's someone who has the right clinical knowledge and expertise to be able to offer patients the appropriate care and tailored treatment, especially in breast cancer where the research is evolving so fast and keeping up with those things. And then it really matters to be compassionate and hear the things that patients say that will matter to them over the course of their treatment. You know, sometimes someone will talk about, oh, and you know, my husband requires a lot of support and care. They're in, you know, this rehab or this or that or the other in terms of needing physical rehabilitation and things like that. Mm-hmm. So hearing that is important because then you have to say, you know, when you're going through this treatment,
you won't be able to
do those things. And you got to focus on you because in this, especially in the initial recovery period, it's so important. And I've noticed so often that women will want to just jump into it. They want to start doing the things, taking care of everybody else.
It's a natural thing.
Yeah. And so I think it's just so important to hear the subtle things that they say and kind of integrate that into what your recommendations are for the patient. Because at the end of the day, I think a lot of people, they get overwhelmed with the data and the numbers and the choices. And I've had so many women just say, if this were your mom, what would you do? What would you recommend to your mom? And so I think that's the approach you have to have with people is that if this were my family member, this is what I would be telling them.
Right. Yeah. And so, you know, a lot of people get the white coat syndrome when they come in and they're, you know, intimidated. And what do you say to that woman who's concerned about feeling rushed or unheard?
Well, I think that I tell them typically that all the questions are not going to be answered in this first visit. So it's really important to, once you have that first visit, that you make note of things that come up and that you have questions about, because how often it happens that even when we go to the doctors and we go back and we're like, oh, I forgot to ask them that question. And then you feel like you never have the opportunity to do it again because it's so hard to get a hold of someone. So I think leaving that line of communication, using the messaging system to say, today we talked about all these things. It's a lot. So after today's visit, if anything comes up, you send us a message, you ask questions, I will call you and let's talk about it, because you're going to hear about half of what I said, and we need to have multiple conversations to make sure that you really understand.
Yeah, that's very fair. And so let's talk about what comes after the surgery. Some patients say, no one prepared me for after treatment. You know, like you said, the drains or, you know, the swelling or, you know, potentially a lot of discomfort that initially, what do you say to that patient in terms of the after surgery?
Yeah, I think that you mean, so the patient who comes to us after surgery and says, I wasn't told, or
they're kind of shell shocked.
Yeah.
Like, you know, I came into this, now I know she said I was going to have drains, but like I really have drains.
Yeah. So that's definitely happens. And so what I've actually started doing ahead of time is, when we're in the room, I will show the patient, because the drain is very similar to the manual blood pressure cuff that, you know, when you push that.
Yes.
Yeah. So I will show them, this is what this is going to look like.
So giving them a visual.
Yes. Okay. Yes. And saying exactly what it entails so that they know. And most women will come in and say, I've heard about these drains. I know about these drains. And so, yeah. And then, you know, a lot of the time I just say, this is what we do for pain. So we do a lot of documentation and patient instructions information. But again, it's so overwhelming. There's just so many thoughts going through the mind that even if we say it, sometimes it just right over the head, because it's like, I'm not really thinking about that right now. But when it happens and then it's afterwards, it's kind of like, oh, okay, well, I'm in pain and no one is addressing my pain. And
right.
And so we just always leave that line of communication open to talk about it.
What do you hope for your patients as they walk away, you know, beyond just survival?
I hope that they understand that they are strength and their ability to get through all of that they did is something that they should be very proud of. But it shouldn't be that it should restrict them in a way that they feel like they have to be constantly anxious or worried about, what if this comes back? What if this, because once we go through the treatment and we get through it and they feel great, it's the year after, the 2 years after, every mammogram they go to, what if this is seen again?
Mm-hmm.
What if something happens again?
The fear of recurrence.
The fear of it coming back. And I think that we can't address that so well, especially as surgeons, because then we're not typically seeing them as regularly.
Mm-hmm.
But I really hope that people walk away knowing that what they just went through and the treatment they just did is something to feel proud of, and know that they have the strength within them to get through anything moving forward. Mm-hmm. And that while there's always this risk of the cancer coming back with any type of cancer, that they should live their lives as they want and do the things that they want to do without feeling limited or restricted by that fear.
Yeah, because fear of recurrence is real. And like you said, it happens.
Yes.
And so I guess you all give them some tools to manage that thought process,
right?
I would imagine.
Yeah. And I think probably that's somewhere where we can do a little bit of a better job, because I think a lot of the question is, how come I'm not getting full body imaging and all these things, and being able to kind of communicate the utility of the tests that we have over testing versus making sure we're following appropriately.
Oh.
That kind of communication is really critical. And it's a hard conversation to have, just because we may not meet in the same place, I think.
The over testing. Mm-hmm. Can you talk a little bit about that?
Yeah. So I think a lot of times what'll happen is you get your treatment, and then the question will be, well, how do we know how are we not checking? How are we checking that the cancer isn't coming back? Are we checking the whole body? But those are not the guideline recommendations. And there's different surveillance for different types of disease. So not everybody is going to have the exact same surveillance strategy.
Oh.
So it really depends on what was your tumor biology, how advanced was the tumor, because that risk of it coming back is going to be dependent on those things. If you had a more advanced disease, the risk of recurrence is higher. If it's earlier stage, that risk of recurrence is lower. So over testing is essentially doing a bunch of imaging that doesn't yield really high results because that risk is so low. So the benefit of doing it is actually not there. And there's actually potentially more harm, because then if you find something, we have to biopsy it. There can always be complications from biopsy, and it may have been a completely unnecessary procedure. So I think that balance of, I want to keep an eye out, but I don't want to overdo what I'm doing with my imaging. Risk of radiation, risk of the dyes that we have to inject. There's risk of all those things. So we got to balance how we look out for it and how much we're doing to look out for it.
Yeah, because I can imagine most patients are very eager to have a PET scan.
Yes.
For instance,
yes.
I mean, that's the big one.
Right, exactly.
That it's my understanding the PET scan does the whole, or at least from the
whole body.
The whole body,
yeah.
Yes. But they can order a PET scan from the waist up. Is that correct? Or is it normally just the whole body?
Typically, it's the whole, they're scanning, yes. But what we're looking at is the waist up. So those are the places of concern. But again, that's not going to be a completely benign thing to do when it may yield, we see something that lights up. Is that something? Is it not? Then it leads to anxiety. And then if this risk was never really that high to begin with, we've just gone down a rabbit hole. So that balance is it's very important, but it's a hard conversation to have, to make people kind of understand that too.
So once you're finished with your surgical responsibilities, the patient is then handed off to the oncologist. Are you still involved in some aspect, or? Yeah,
so I guess that kind of depends. So usually if a patient needs, further, because after surgery, there may or may not be radiation after that. And then usually about 6 months after radiation, we'll see the patients back just to make sure everything looks good. But if it's just another added appointment and we're not doing anything more because we're not doing any more surgery, then we'll kind of say, okay, this is where you will be followed by the medical oncologist.
I understand.
If somebody eventually wants the other breast removed because they had a BRCA mutation and we could only do the one breast the first time, I'll see them back. We'll go back through that whole kind of cycle of doing the final surgery for them. But usually after the postoperative visit, maybe another follow-up visit, but then they continue with their medical provider.
So what would you say as some of your closing thoughts just about your contribution to patients seeking and needing a breast surgical oncologist?
So I think being where I am at MD Anderson has afforded me the opportunity to pursue a lot of the research interests that I have alongside the clinical care. And so for me, my clinic, my patients, that is the crux of everything. So I like to be clinically busy. I love to operate. I love to take care of patients. But I think on the flip side of it, understanding the advances in the field, where we may have some unmet needs that we need to address with a deeper thought, a deeper dive into what is it that we're achieving and how are we getting there, reducing some of the disparities in care is also really, really important. So I think in some of the research interests that I have and combining that with the clinical scenarios that I see and kind of what provokes the thoughts of, oh, well, how can we make this better? What can we do to make this better? So we're constantly kind of working towards that simultaneously.
Well, thank you for all that you do. And, of course, MD Anderson is, world premier cancer institute that services so many women and men from around the country for not only breast cancer, but all cancers. And so we appreciate you coming and talking with Sis Sisters in Survivorship. Thank you so much, Dr. Tamirisa.
Thank you so much for having me. I really appreciate it.
The motivation working in oncology is easy. I think we all have a family member or a friend that's affected by cancer, and you just know the toll that takes on not only that person, but their family.
While I might not today be in one of those situations where I desperately need a medicine for someone I care about, millions of people are all over the world in that exact situation. Like, we are the people who make those things.
No shortcuts, no compromises. We discovering, we identifying, we applying cutting-edge technologies and the methodologies in our daily work. Whether I can improve with new technology, doing something faster, I'm always trying to get better in every experiment that I'm running.
I think we constantly have to be pushing those boundaries, not just so that we can stay at the forefront as a science and technology company.
Being bold with ideas can really help us make breakthroughs and bring us step closer to discovering effective treatments for patients.